Chapter 47, Hydronephrosis. Obstruction to the outflow of urine down the ureter is of two kinds. 1, sudden complete obstruction. 2, gradual or incomplete obstruction. Sudden complete obstruction occurs clinically under two forms, these by a calculus and by the surgeon's ligation. In either event, the result is the same. The urine is dammed back upon the kidney, causing an acute renal congestion and a diminished secretion of urine. But even this increases the intrarenal pressure. The congestion is exchanged for atrophy after little dilatation has occurred, thus terminating the usefulness of the organ. The details of these changes are described under calculus and urea. Gradual, incomplete, or intermittent urinary obstruction sets up a very different train of events. Some urine escapes past the obstruction, continuously or from time to time, and affords partial relief to the renal tension, while still keeping up a very considerable pressure. Thus, the organ does not atrophy. It continues to excrete an amount of urine equivalent to what can pass the obstruction, while the continued high pressure within the kidney causes a gradual dilatation of its cavity. Pelvis and calyces gradually dilate, and there is hydronephrosis, cystonephrosis, nephrectasis, renal distension, uronephrosis. The above described pathogenesis of renal atrophy and hydronephrosis has been experimentally worked out by Guyon, Byron Robinson, and others. The influence of infection in causing hydronephrosis is not clear. All specimens of grave chronic renal infection exhibit some slight dilatation of the renal pelvis, even though there be no appreciable obstruction. On the other hand, there is a priori reason to believe that grave chronic renal infection does not occur in the absence of all retention. Furthermore, animal experiments have shown that infection is a predominating cause of hydronephrosis. Even the kidney, whose ureter is closed by ligature, becomes hydronephrotic if mildly infected, while infection of the non-stenosed ureter causes hydronephrosis. Etiology. The cause of hydronephrosis is gradual, incomplete, intermittent urinary obstruction. The obstruction may be either urethral or ureteral. Urethral obstruction. The common urethral obstructions are stricture and prostatism, but the former always, and the latter usually, damages the kidneys more by infection than by dilatation. The bladder bears the brunt of the distension, and although the kidneys and ureters become dilated by chronic urethral obstruction, figure 49, this dilatation is clinically subordinate to the inflammatory features of the disease. Ureteral obstruction. Ureteral obstruction acts differently. No distensible bladder intervenes to distribute the pressure, and infection is often entirely absent, so that the aseptic dilatation of kidney and ureter progresses rapidly and unobscured. The ureteral obstructions are 1. Obstruction from within by stone, tumor, or foreign body, figure 80. 2. Pressure from without by aberrant renal vessel, figure 98, or by pelvic growth. 3. Kinking of the ureter from nephrotosis or misplaced kidney. 4. Strictures and valves of the ureter, especially those caused by anomalous origin of the duct or by stricture at its termination. 5. Congenital dilatation of the whole ureter with the kidney, either with or without stricture of the vesical orifice. 6. Trauma to the kidney causing true or pseudo hydronephrosis. 7. Ureteral trauma, whether partial division of the duct, stripping it of its blood supply, as in the Wertheim operation, or ligature. Ligature with simple catgut leaves a permanent stricture. Figure 98, hydronephrosis from ureteral compression at A by a branch of the renal vein. This obstruction caused an intermittent hydronephrosis, which was permanently cured by the liberation of adhesions and nephropexy. Roberts has examined 52 cases in reference to their etiology. 20 were bilateral and 32 unilateral. The cause was congenital in 20 cases. In 2 of these, a supernumerary renal artery crossed and compressed the ureter near its origin. In 4, the ureter was congenitally imperforate. In 4, the ureter entered obliquely into the pelvis of the kidney. In 1, the ureter was kinked and adherent. In 1, there was stricture at the vesical extremity. 13 of these congenital cases were bilateral. Of these, 2 were stillborn, 5 died within 6 months, 3 within 48 hours after birth. 4 lived from 5.5 to 20 years. 1 survived to the age of 38. Of the 32 cases of acquired hydronephrosis, 11 were due to impacted ureteral calculi, 3 others were attributed to the same cause, 5 showed inflammatory or ulcerative stricture, 9 were occluded by external pressure, by peritoneal adhesions, 3 cases, gravid uterus, ovarian cyst, cancerous growth. Morris has analyzed 142 cases, of which 128 were due to obstruction of the ureter, by cancer of the pelvic organs, 118, cancer of the abdominal organs, 3, ovarian cyst, 4, and constriction of the ureter, 3. Yet, hydronephrosis due to cancerous obstruction is rarely noted except post-mortem. The so-called traumatic hydronephrosis is almost always an encysted perinephritic extravasation. A special cause of hydronephrosis, a cause that figures but rarely in statistics and yet is commonly encountered in practice, is nephrotosis. Certainly, renal mobility is associated with practically every case of intermittent hydronephrosis, and in a great majority of hydronephroses due to kinked and adherent ureters, whether over an aberrant renal vessel or not, and to oblique implantation of the ureter in the kidney pelvis, the first kinking of the ureter or pouching of the pelvis is attributable to a nephrotosis. Figure 98.